Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Medications and Breastfeeding. Following the webinar, please be sure to follow the instructions alongside this webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free North Carolina CE credit. I'm Amy Holmes and I'm your speaker today. I am currently a NICU pharmacist at Wake Forest Baptist Medical Center, where I frequently have questions about medication safety and breastfeeding. I have no financial relationships or conflicts of interest to disclose. We are going to discuss pharmacologic properties of medication passage into breast milk, identify resources available for assessing safety of medication use in breastfeeding mothers, and determine the safety of medication use in breastfeeding mothers. We'll start out by talking a little bit about lactation physiology. Lactation actually begins during pregnancy, and once the baby is born, moves into the colostral phase, and then finally within usually the first 3 to 7 days after delivery, the secretory phase, where women produce some more mature milk. And this is important to understand, just that milk is produced on the basis of supply and demand. So hormonal changes associated with lactogenesis, when the baby's delivered, you have an increase in oxytocin and prolactin and a decrease in progestins and estrogens. And then as the baby feeds, that skin-to-skin contact further increases the oxytocin and prolactin, which stimulates mom to produce more milk. And then as the baby feeds, that's just a further trigger to mom's body to produce more milk. And it's important to understand that in the context of medication use, that if we interrupt that breastfeeding process due to medications, it can break the cycle of establishing good lactation. Also related to lactation physiology, understanding the lactocytes. Here is a cell, and you can see to the left of the cell where there's a really tight junction, and that's later in the secretory phase. However, in the colostral phase, over to the right, you can see there's more of a gap, and so you get actually more passage of medications into colostrum in that early milk. However, it's thought to be that the volume of that milk is usually so low that it would not be clinically significant. Medications do pass into breast milk via passive diffusion. So knowing that, we can avoid when the potentially for some medications, avoid breastfeeding when those medications are at their peak. So that is one strategy you may sometimes use to prevent or at least avoid having a maximum concentration of a medication in breast milk. And then there are actually a few items that have active transport into breast milk. Cimetidine is one. It's rarely used. Acyclovir does have some active transport mechanism, but still not clinically significant amounts found in breast milk. And iodine is one probably to worry about only if there are iodine-rich supplements being ingested by mom. Typical amounts of iodine in the diet are not a concern. So there are several properties affecting medication and milk that I want to talk about, and the first is molecular weight. Smaller items are more likely to pass into breast milk, and the larger the molecule, the less likely it is for these drugs to pass into milk. So if you think about something like IVIG or insulin, large proteins, they would definitely have a hard time passing in the milk. And smaller molecular weight items, so lithium is a good example, as a very small molecular weight, less than 200 Daltons, are more likely to pass through. Now, as I talk about these properties affecting medications in milk, I think it's important to understand these are really things to help us understand the data when we have, when we try to make a decision about whether a medication is safe in breastfeeding. Sometimes we'll have a few case reports and we have early data, but these can help us reassure us based on the properties that we know whether things are getting into milk or not, but we use that in conjunction with hopefully data if that's available. Lipophilicity, drugs that are lipid loving or lipophilic are more likely to pass into breast milk. Drugs with a larger volume of distribution are less likely to pass into milk. As I said, most medications pass through passive diffusion from the blood, and if the drug has distributed out into other tissues and is not readily available in the blood, then it is not available to pass into the breast milk. So large volumes of distribution can mean little drug into the breast milk. Likewise, drugs that are highly protein bound, they're not free in the plasma to diffuse into the milk. That can have an effect as well. pKa is maybe something some of us have not heard since chemistry or pharmacy school. It's not something that we think about in our daily lives as pharmacists usually, but it's helpful to understand that drugs with a higher pKa, so if it's greater than 8, these medications can pass into the milk, but then it's called ion trapping. They get trapped in the milk because they get ionized and can't pass back out of the milk. And then bioavailability may or may not directly affect the medication passing into the milk, but it's important because some drugs you consider are not orally bioavailable, then you would not expect the baby to ingest them even if they're in the milk, or be able to absorb them even if they're in the milk. But also things like inhalers, for instance. You're not getting systemic absorption, then they should not be able to pass into the breast milk. Topical agents are another good example. If you have a limited systemic absorption, then you would expect limited ability to pass into milk. Some lactation references publish a milk to plasma ratio, and that's the amount of medication in mother's milk divided by the amount in the plasma. And if this ratio is greater than 1, that indicates that there's sequestering in milk, whether it's because of that ion trapping or some other reason. This is just an indication that you may have higher concentration of milk, and it may be a less desirable drug in breastfeeding. Many papers now publish a relative infant dose, which is the infant dose divided by the maternal dose per day, and it's expressed as a %. And a general rule of thumb is that if the relative infant dose is greater than 10%, most people would recommend that it's not compatible with breastfeeding. And if it's less than 10%, that usually indicates that it is acceptable. When you're making decisions about whether a drug is safe to use in breastfeeding, it's often helpful to know the age of the infant, whether it's a term or preterm infant, if they're a newborn versus a 6-month-old. Some of that has to do with understanding the ability to absorb and excrete medications, their reliance on milk for nutrition, or the amount of exclusivity of breastfeeding. For instance, a baby who is newborn and is getting their entire diet through breast milk may have a higher exposure compared to their body weight versus a baby who is only breastfeeding either a few times a day as mom is weaning, or because they're getting table food, they're getting less volume. That's not their entire diet. Relatively speaking, they're getting a lower potential exposure. And then it often happens in our NICU that moms, because they're having to pump milk and they're not able to breastfeed their baby, they don't always have enough milk to keep up with supply. And so their milk is already being, you're using some formula to supplement. And so taking that into consideration, that the exposure is further limited by the fact that it's being diluted with something else. And sometimes that aids our decision if we have a medication, or often it's when there are multiple medications that have the potential to cause sedation, if we know that that's somewhat mitigated by the fact that they're not getting full breastfeed, and then you also have them in an environment where they can be monitored, then we'll very frequently use mom's breast milk because of all the benefits of breast milk. And that brings us to risk versus benefit. And all of these decisions really should be looked at as a risk versus benefit, because there is definitely potential risk in giving drugs that may cause adverse reactions, but there's also risk in not providing mother's breast milk because we know that there is so much health benefit to breast milk. So we have here the risk of exposure to individual medications balanced against the benefits of breast milk itself. And I just have a few listed here. A reduced risk for sudden infant death syndrome being a very important one. Fewer infections, things like otitis media, are lower in infants who are breastfed. So what's our role as the pharmacist? I think number one, making sure we provide accurate information. And we're going to talk a little bit about where that information comes from, because not all information is created equal when it comes to drugs and breastfeeding. And then recommending preferred alternatives when necessary. That may or may not always be appropriate, and you may not always have that opportunity. But knowing where to find that and how to think that through, I think is helpful if this is a population that you serve frequently. And one of the reasons I always try to cover this topic when I have students, I have students who come through on rotation who may never come into a NICU again, but I feel like as pharmacists, no matter where we practice, we are likely to have questions about drugs and breastfeeding, even if it's not the patient population we serve. It may be the nurses we work with or family members, but it is a part of drug knowledge that not everyone feels comfortable with. But some may expect us to know just because that falls under a pharmacist's purview. So hopefully you'll feel a little more confident with that if you didn't before by the time we go through some more of this information. So I have a few drug classes that I want to talk through. Anesthesia is one I always mention because in the hospital we've definitely had ladies who've been advised not to breastfeed for any given amount of time, 24 hours, 48 hours after anesthesia. And the data is really does not necessarily support that. And the World Health Organization actually lists anesthesia as being compatible with breastfeeding. And I believe in more of the references are starting to have more of the individual drugs as well. But remember we talked about passive diffusion, the substance has to be in the bloodstream in order to pass into breast milk. And generally, once a mom is awake and alert, if she feels like she can breastfeed, then she should be able to breastfeed. Anesthetic drugs are rapidly cleared and should not be getting into milk if they're not present in mom if she's awake. So sometimes we are able to intervene and allow mom to breastfeed earlier and debunk some of that misinformation that she's received. Contrast is another big one that comes up frequently in the hospital. It does have low passage into milk. For the oral contrast, has poor oral bioavailability, so you wouldn't expect it to even be absorbed in mom, let alone pass into milk. But even for IV contrast, you would expect low passage into milk. And the American Radiologic Society actually suggests it's safe to continue breastfeeding following use, but this still sometimes is an unknown area, and we get questions frequently in the hospital about that. Most antibiotics are compatible with breastfeeding. I do have listed sulfamethoxazole and trimethoprim to use caution in particular age groups of infants, and really has to do with the concern for hyperbilirubinemia of the neonate and then the potential for G6PD deficiency. Anticoagulants, I like to stop here and just say another myth or I guess misconception that some folks have had that I've encountered along the way have been that medications that are contraindicated during pregnancy are also contraindicated during breastfeeding, and that's not the case always. Sometimes it is, but there are different mechanisms, and so you will sometimes find things that moms have not been able to take during pregnancy that they are now able to successfully take and still be able to breastfeed. Um, Low molecular weight heparins and warfarin are both compatible with breastfeeding, and warfarin here being what I'm talking about. Women usually, except for very extenuating circumstances, very specific cases, do not take warfarin during pregnancy because of the risk of harm to the fetus. But it is considered to be compatible with breastfeeding, perhaps one reason because of the high protein binding, but there's data to support that warfarin is compatible with breastfeeding. Low molecular weight heparins are used during pregnancy and then may also be continued following delivery as well if a mom is breastfeeding. There is, however, less data at this time with the newer oral anticoagulants, so generally they're not recommended just based on that lack of data, which hope, at some point we may have, but at the time of this recording is very limited. Anticonvulsants, a couple things to consider, and I'd say this is probably true in a lot of the medications, but particularly anticonvulsants. When initiation of exposure, was it in utero, or is this a new start? Some of the medications, if they've been exposed all through pregnancy, their risk was probably higher in pregnancy than during breastfeeding, and so you would weigh that concern. If it's a new start, maybe being able to actually switch to a drug that's more compatible with breastfeeding. Ironically, the older agents, which we know have concerns during pregnancy, actually often have less drug in milk because of their higher protein binding, and some of the newer agents will have more drug in the milk because of the lower protein binding. With that said, things like Lamictal and levetiracetam are generally considered safe in breastfeeding, but I would there were lots of things to consider there, and so I don't have particular meds on this slide. I would advise looking into each of those individually if you have questions. In general, for antidepressants, SSRIs are preferred. Some tricyclics are considered acceptable. There are definitely ones that are recommended to avoid that I have listed here. For antihypertensives, we have some groups that are preferred. Again, ACE inhibitors being medications that can't be used during pregnancy, but can be used during breastfeeding. Almost all of the beta blockers are acceptable, except for atenolol specifically is recommended against in breastfeeding. Thiazide diuretics are preferred over loop diuretics. So if you have a mom who's starting on a new agent postpartum, you have a lot of options here for preferred agents. For antipsychotics, you have here again a list of preferred in breastfeeding and the couple that are recommended to avoid in breastfeeding. If these are new starts, definitely we would want to prefer or recommend one that's preferred in breastfeeding. I am a little less comfortable recommending a change in an antipsychotic medication immediately postpartum. I feel like that's not a good time to be, because a woman is already at risk for postpartum depression and all the things that go along with all those hormonal changes. Probably not the best time to be changing her regimen. And also, from my perspective as a NICU pharmacist, I'm very often taking care of the baby and not the mother, and so I'm not directly involved in her care. And usually I'm making recommendations to say these are things you can consider if we're having to tell her that something is not compatible with breastfeeding, and that kind of leaves it up to her to talk to her outpatient physician. So another reason why personally I'm hesitant, it doesn't mean that it can't be done for sure, but I don't have a lot of experience with doing that. And I do think it's worth considering when making those recommendations. Contraception is something that is usually discussed before the end of the pregnancy. I know in the hospital we often will do Depo-Provera. There are a lot of other of the long-acting reversible contraceptives that are starting to be used in hospitals more. But definitely when a woman is breastfeeding, non-hormonal would be preferred, but also progestin only would be acceptable. Estrogen containing is contraindicated in the first 6 weeks postpartum, but also if a woman is breastfeeding, should be avoided. In general, lipid-lowering medications, specifically, I guess, HMG-CoA reductase inhibitors, you worry about the effect on composition of milk. So it's less about the actual adverse effects in the baby as it is about the effect on the content of the milk itself. And so that is a class that's usually recommended not to use during pregnancy or breastfeeding. Cholestyramine is not really used much anymore, but it is acceptable in breastfeeding because it's not absorbed. For over-the-counter medicines, in general, acetaminophen and nonsteroidals are acceptable. With anything that you're using PRN, the lowest dose and the less frequent, you can use something the better. Decongestants, there's mixed information. I usually say if a mom is really, really extremely uncomfortable and one dose would help, then one dose is probably okay. The real concern there, if you use a lot, is causing irritability in the baby. But also there's concern for diminishing her milk production. That's another concern with some medications, and decongestants happen to be one of them. And then with antihistamines, the non-sedating antihistamines are usually preferred. Most opioids are acceptable, again, in small doses and intermittent doses, specifically avoiding codeine and pyridine. Those are two opioids that are contraindicated in breastfeeding. So medications that are administered to mom post C-section, usually she's not going to be taking those for a long time. We talked about surgery earlier. If mom's getting a little bit of morphine post-op, it's not a reason that she can't breastfeed, but if you see that she's taking larger doses or more frequent doses, that might be a time when she maybe needs to discard some portion of her milk and not breastfeed due to concerns for sedation. Methadone and buprenorphine, when they're used for opioid maintenance therapy, so the baby has been exposed throughout the pregnancy and now is getting exposed through breastfeeding, actually can help decrease the severity of symptoms of the withdrawal that the baby will have based on that in utero exposure. So they'll have decreased need for pharmacologic treatment and then actually have shorter lengths of stay in the hospital for treatment. There's no limit on the dose that mom is taking. And as long as we know mom has been compliant with her sobriety, then we encourage breastfeeding for moms on either one of those medications for opioid maintenance. And I have included a few studies. There are still people, despite the data, that are a little uncomfortable with this. But you can see from Abdul Latif, there was a retrospective study, and they showed a length of stay for treatment, 15 days versus 19 days. And then for requiring pharmacologic treatment, 52.9% versus 79%. Dryden showed that breastfeeding for greater than or equal to 72 hours reduced the odds of receiving treatment for NAS. Eisman showed that breastfed babies have a shorter length of stay. And Wellstrand also included buprenorphine. Most of the studies, earlier studies, were with methadone. And they showed a shorter duration of treatment for the methadone group. There was no difference in the buprenorphine group. However, there were still no adverse outcomes, and I think that's part of what we have to keep in mind as well, that we don't, even though we're not getting the positive outcomes, we still don't want to stop mom from breastfeeding and being able to provide all those benefits of breast milk. I will mention too that one thing to be concerned about if mom stops breastfeeding abruptly and she's been breastfeeding during while taking methadone or buprenorphine, the baby can actually go into withdrawal following the sudden stop of breastfeeding. Illicit drugs are always contraindicated. Most of them are extremely dangerous. With that said, marijuana is extremely controversial. There are folks who do hour-long talks just on that, and I'm definitely not the person to do that. The reason it has become controversial, I guess in some states it's no longer illegal. Some people argue that it's no worse than tobacco smoke as far as the effects on the infant. Acute intermittent use, there's probably not as much concern for passage into milk, but with chronic and heavy use, there's definitely more passage into milk. So I will leave that there, and hopefully not something that you're going to be dealing with in a in your setting. But unfortunately, it has been a very hot topic over the last couple of years. Alcohol is a little more clear. Chronic or heavy alcohol consumption is not compatible with breastfeeding. The AAP does say that if occasional, social drink here and there is acceptable, the limits are listed on the slide, and the recommendation is that breast milk should be pumped or fed more than 2 hours after the ingestion of alcohol. Tobacco smoking is not an absolute contraindication. It should be avoided in the presence of the infant. And tobacco, I always say, I feel as a pharmacist, I need to say that tobacco use should always be discouraged. But the benefits of breastfeeding despite smoking are still there. So if a woman is going to smoke and have a baby, it's better for her to smoke and breastfeed than to smoke and not breastfeed. Nicotine replacements in general are acceptable. At one point in time, there was a school of thought that a patch was better than gum because of the consistent amount of nicotine versus spikes and peaks of nicotine that you might get from gum. The inhaler was a preferred route because of the lowest concentration. I think there are even newer replacements out that I'm not familiar with, so that may be an evolving field. I would recommend looking up any of those if you're not sure, but in general, the last time I had looked at the ones available, they all were acceptable to some degree. Routine postpartum vaccines are considered compatible with breastfeeding, and I have them listed here. It is recommended, varicella and MMR both being live vaccines, of course. The only time you would really be concerned is if you had a severely immunocompromised infant. Otherwise, they are considered to be safe with breastfeeding. Chemotherapy, you would expect not to be able to breastfeed. It is not an absolute contraindication. I'd just like to say be open to evaluating the regimen. We actually had a mom that we were able to help breastfeed. It was only for a short time. She was diagnosed with cancer during her pregnancy and started her first cycle of chemo while she was still pregnant. And she had a break while her body healed from delivery before her next cycle. And we were able to figure out how long from her last cycle to wait before she could breastfeed. And she had a little window. With the chemo affecting her fertility, she really knew this was her probably only chance to have a child and breastfeed. So that really meant a lot to her. So I encourage you to be open-minded to at least check into it. Odds are it's not going to work out, but it may. And I guess you just don't know until the circumstances come along. Information resources are definitely important, where you get your information. Medications in Mother's Milk is a book that I have used quite often. It's published by Thomas Hale. It's available also in an online version. Drugs in Pregnancy and Lactation, many of you may be familiar with, is a good reference. LactMed is actually the preferred reference, and we're going to talk a little bit more about that. The AAP has a statement, and I have them further down this list. They used to publish a list of drugs that were compatible with breastfeeding and drugs that were contraindicated with breastfeeding, and eventually they stopped trying to keep up with all the new drugs coming out and just basically said LactMed is the go-to reference. If you're not familiar with LactMed, you basically can Google it, but it is a drug information database. It's through the National Institutes of Health. It's free. Anywhere you have internet service, you have access to LactMed. They also have a free app that you can download. So I highly encourage you, if you ever get these questions, to have this reference bookmarked or the app downloaded, just have it available for your use. If you have Micromedics available to you, it can sometimes be helpful. The PDR or package labeling, I would recommend against using. The World Health Organization and UNICEF have some data, and not as easily accessible and user-friendly, but like I said before, that's where I found I've looked to that for things like anesthesia recommendations, some of the maybe more obscure things. And then I think something that we forget about, First Data Bank, Medi-Span, these are the resources that are driving the drug interaction or your drug interaction software if you have an electronic health record. And sometimes you're getting flags for, you're not necessarily going to that to look up something, but you may get a flag on order verification or order entry. So I have a couple slides here just showing you Dr. Hale's lactation risk. This is from Medications in Mother's Milk. He puts them into categories. L1 compatible, L2 is probably compatible, L3 is considered probably compatible, but if you read the little box, some drugs may go in this category even if there's no studies, but they think that it will be minimal based on those drug properties. Potentially hazardous is an L4, and then L5 is hazardous. So I generally think of anything in L4, L5 as contraindicated. L3 is usually where I really want to delve into the further information, read the what case reports they have, look at the molecular weight, try to help discern, whether we feel like this is something that needs to be, can we use this and monitor for whatever side effect, if it's may affect an electrolyte, do we need to get labs, that sort of thing. L1 and L2 are generally pretty comfortable saying that they're safe in breastfeeding. With the FDA labeling rule, this went into effect June 30th of 2015, but it's just finally in 2020 being complete. It was kind of a rolling calendar where different drugs, depending on when they were approved, had to have their package labeling updated. And some drugs, depending on how old they are, that don't have to have this labeling. But this is helpful for if you are going to use this information, if that's all you have available to you for some reason, that with this new labeling rule, manufacturers are supposed to include information like actual studies. In the old way, a lot of them had generic statements, cannot verify safety in breastfeeding. They don't want to tell you that it's safe and I guess put themselves at risk for litigation. I always felt like it was there was always some type of stipulating statement in there, but this gives you more science, more of the data is actually available in those newer package inserts. So a colleague and I decided to look to see if the pregnancy labeling rule and some of this, I guess, increased focus on drugs and lactation had changed anything in references. There had been a study published in 2007 that had compared commonly used references for commonly used medications to see if basically if the recommendations were similar, and they varied a great deal, which tells you that obviously some of them are, well, I say obviously, I would think that means that some of them are less reliable because of science to science, then they should match more closely. So we redid that to see if there had been any impact from the labeling rule. We looked at 19 different drugs and 10 commonly used recommendations or commonly used references. And we also found that the references or the recommendations varied. So this is some of the things that we found in Medications in Mother's Milk and LactMed. 13.5 were found to be safe, and I'll explain the half. So for medications like metronidazole, a 500 milligram BID course of metronidazole is generally considered safe with breastfeeding, but if a mom had a 2-gram one-time dose, then there would be concern about breastfeeding for a certain amount of time after that large dose. And so if there was a caveat, we gave it a half. Safe got a 1, and then if it wasn't safe, it got a 0. So you can see that medications in Mother's Milk and LactMed are pretty close in agreement. They found that about 13.5 of the medications that we looked up were compatible with breastfeeding, where on the other end of the spectrum, the PDR online only found that 1 medication was compatible with breastfeeding. Also, you'll notice that Malta, Medi-Span, and First Data Bank, those are the databases that drive the drug interaction screening that you see in things like Epic and the other electronic health records. they had a lot lower number of medications considered safe in breastfeeding. So you're getting a lot of flags for things that medications on mother's milk and LactMed might tell you are safe in breastfeeding. So some inconsistencies there. We looked at the number of references per resource per medication. You know, if we're getting our information basically third hand because they've taken the data and compiled it into a recommendation for us. What are they using for their recommendation? And you can see some spikes, and those are primarily LactMed, who typically had the most number of references. And this has the date of the most recent reference. And we really only looked at the three top recommendations are the ones that had the most drugs that were recommended as safe, so we didn't look at all of them from this perspective. And oddly enough, there were some that really didn't have references, so we couldn't include them and compare. But you can see that we have a lot more recent references in Micromedics and LactMed. And very often the most recent reference in Micromedics was the actual package insert. So in general, we feel like this supports AAP's recommendation that LactMed is the preferred reference based on the amount of evidence and how recent the evidence that they use to make their recommendations. We did a pharmacist survey in North Carolina as well, and I just wanted to share a few of the results. We had 754 responses, which was a 6.5% response rate. More than half have been in practice for less than 10 years of those who responded, and half felt that they had references readily available to them. Now, hopefully, if you've listened to this talk, everybody will feel that they have a reference readily available to them now that you know about LactMed, if that's not something that you know about before. So this is just a snapshot of who participated, and the majority of the respondents were community retail, with the next number being health system, hospital, community. And also we wanted to know what's your comfort in making these recommendations, and you can see almost half agreed that they felt comfortable, with another portion that strongly agreed. So more than half of pharmacists in North Carolina who responded to the survey are comfortable making recommendations. There's still a lot who aren't comfortable, so hopefully if you were in that group and you're listening to this, then you feel a little more comfortable now. The preferred reference for almost 60% is the package insert. Several also used Lexicomp, Hippocrates, LactMed, and other. So I wanted to talk just a couple of minutes about galactagogues. Hopefully you're familiar with that word. Medications that are used to augment breastfeeding. Metoclopramide is is the only prescription drug available in the United States for assisting with milk production. It works by increasing prolactin. The dose I have here, 10 milligrams 3 times a day for 7 to 14 days, although some folks consider tapering because there is some evidence that the effect goes away once the drug stops. So there is a school of thought that tapering it over a longer period would prevent that turning off of the breast milk production. Obviously with metoclopramide, the concern here is tardive dyskinesia. So there are some who are hesitant to use it. It's definitely something that moms who are considering it need to be made aware of before they begin to take it, if that's something they want to do. Domperidone is not available in the United States, and when I first heard about it, I thought, well, I don't really need to bother to learn about this drug that's not available in the United States. But I would still have babies in the NICU whose moms were taking domperidone that they had gotten either several years ago. You could still get through compounding pharmacies in the United States, but I think that's all been stopped now. But women are still getting this product from Canada. It works the same way as metoclopramide. It increases prolactin. The dosing's the same. The tapering consideration's the same. The big benefit is there's no risk of tardive dyskinesias. The big drawback and why it's not available on the market in the United States is because of risk of arrhythmias. Now, with that said, it was pulled from the market when it was being used in higher doses for post-op nausea and vomiting when it was associated with arrhythmias. From what I've read, it's used extensively in Europe and Canada and is safe. I'm not advocating for its use, but I do think for those reasons, because it is considered to be safe in these other areas and that moms have this available to them, that it's good to just be aware of its existence. I say fenugreek is usually the product that your girlfriend will tell you about. Women often tell each other that this works for breastfeeding. The science does not necessarily back that up. There is some thought that it's a placebo effect that helps fenugreek work. It is an herbal supplement, not a medication. It's on the list generally recognized as safe. But again, with it being an herbal supplement or dietary supplement, it's important to remember that content may vary and products are not regulated. As pharmacists, I think one important factor for us to know is that fenugreek can actually affect the INR. And with clot risk being associated with pregnancy, you may have young women who are on warfarin and taking fenugreek. There is a whole host of other herbal supplements that have been reported to increase breast milk production. There's really no scientific evidence that they work, and I generally do not recommend any of these. The ABM, the Academy of Breastfeeding Medicine, has a list of things that they recommend for helping establish breast milk before relying on medications. So they're not big on herbal supplements or medications at all. So there's definitely other things to do, but a lot of these things are still marketed to the public. So just to make you aware. So in summary, I do think as pharmacists, we need to evaluate the risk versus benefit. And again, that being the risk of the medication versus the benefit of breastfeeding. We need to use the most up-to-date resources for information, with LACMed being the preferred reference and recommended by the American Academy of Pediatrics. And we can be prepared with alternative breastfeeding friendly recommendations when possible. So I thank you for participating in this webinar. In order to obtain CE credit, please follow the link that accompanies this recording to complete a quiz and evaluation. Thank you.